Donc, good afternoon, everyone. Welcome to the third edition of the Publique Research Club. Thank you for joining us today. This series is organized by the INSERM Public Health Institute and IReSP with the aim of showcasing innovative research, fostering scientific exchange, and building stronger connection across discipline and institutions in public health. Today, we are delighted to focus on the topic modeling and data for pandemic response. I'll let our director, Robert Barouki, introduce our speaker, Vittoria Colizza. Robert, je te laisse la parole.
Thank you, Laureline. And yes, we are very happy today to have Vittoria with us. I think we know each other for a while, Vittoria. And Vittoria had a very international, actually, career, and she is Director of Research at INSERM, at the IReSP Center at Sorbonne University and INSERM. So she is really an expert, world-renowned expert in modeling and pandemic response. So we are really very glad to have her. And I have attended recently the opening of the SUMOC center of this, and that was really important. And I think this makes us INSERM at the forefront of research in this field, and therefore I'm not going to go into much more detail. Let's hear about this and have a discussion afterwards, Vittoria.
Thank you very much, and good afternoon, everybody. I would like really first to deeply thank Professor Robert Barouki and IReSP for this invitation. Indeed, today we're gonna a little bit discuss what brought us to the creation of this Center for Outbreaks response, and I'd like to do that really step by step, building from the very start on what we do and why we do it. So my work is about developing and using models for infectious disease spread in populations. And clearly after COVID-19 crisis, everybody has been exposed to the use of these models. Here are some titles quite strong by science about the mathematics of life and death and how disease models shaped national shutdowns and other pandemic policies throughout the crisis. But what do we do exactly? So our aim is to develop different types of approaches. These are mathematical abstraction of reality that take into account some basic and essential elements that drive the spread of infectious disease in population. These approaches can be statistical, mathematical, or computational in nature. They can vary a lot from stratified approach based on age to approaches instead based on space or integrating both, or instead approaches that are specific to certain settings. Like, for example, if we want to study what happens for disease spread inside a hospital or what happens when disease spreads inside a school. These approaches are then developed mathematically, and they are integrated with a lot of data. Clearly, we're talking about epidemic data coming from surveillance, clinical data coming again from different types of, for example, hospital surveillance. But a large part of the data that we use that generally go unseen and is not known by the general public is the fact that we need to track and characterize also host behavior. Because we need to understand, for example, how people move from one place to another, as this is the means to bring the infectious disease from an area where the disease is spreading to an unaffected area. And we also need to understand how people interact with them, what kind of mixing they have, whether they mix more at the restaurants, at the workplace, in the household, etc. Because that, again, will drive how the disease will propagate into the population. So the integration of these models with these different types of data, and sometimes we don't have access to the actual data that we need, so we use proxies, and we'll discuss that at length throughout this presentation. So the integration of these modeling, so computational epidemiology and digital epidemiology using this digital data is really to better prepare against infectious disease epidemics, better track when they are diffusing in the population, and also better respond. And to do that, these models really are aimed to estimate what's happening, trying to understand, to provide a context awareness of all that surveillance system cannot tell us about the evolving status of the infectious disease epidemic, but also anticipate the infectious disease epidemic evolution in time, and also test within our models before applying them in the population, whether certain interventions can be efficient in mitigating the infectious disease epidemic, and whether, for example, we could use resources in a more optimized way, for example, with the use of vaccines. Now, let me take a step back and explain you what my reasoning on why we need models. So often, in absence of models before, let's say about almost 20 years ago, we were used clearly to use exclusively previous experience. So looking back at previous epidemic outbreaks, probably previous pandemics, in order to understand what to do with, for example, an ongoing pandemic. Now, the problem is that often with infectious disease epidemics, this doesn't work because the pathogen is different. And if we're talking specifically about pandemics, we're talking about an emerging novel pathogen that the population has not seen before. And so it could affect the population differently. For example, COVID-19 infection and severity was very different from previous pandemic influenza. And even if we refer to the same pathogen type, for example, if we talk about flu and we think about our pandemic influenza episodes, the last one occurred in 2009 and it was caused by H1N1 pandemic virus. The previous one was in the 60s, the previous one was in the 50s. And the biggest Spanish flu was about 100 years ago. But clearly, across all of this time, even though the pathogen may have similar properties, our population and our world has completely evolved. We have different means of transportation today that drive different means and opportunities for exchange, for mixing population at large scale, but also at local scale. So in absence, when we cannot use previous experience, the other thing that we can use, of course, is common sense, which generally is always a good idea, except that common sense fails us when we have to deal with non-linear effects. And the exponential growth of cases, which is the initial growth of cases throughout the start of an epidemic, is a clear example of this non-linearity. There are experiments, cognitive experiments, that show very clearly that our brain is not able to understand the growth that is exponential. We are able to understand the linear growth, and so we are able to understand, well, if cases have grown linearly so far in the past, I can anticipate the linear growth in the future. But instead, we're not able to capture, and this is valid also for many scientific minds, we're not able to capture such a fast growth as the exponential growth. And so we tend to underestimate this growth. There was a nice experiment that was conducted throughout the COVID-19 pandemic crisis in the United States, in which individuals were exposed to the growth of cases of the last few days, and then they were asked to predict and anticipate what was the expected growth in the following near future. And what the scientists found is that everybody strongly underestimated the growth. And they found something even more interesting. They found that, for example, depending on the political ideology participants belong to, which typically is associated also to exposure to different kind of information on the epidemic, for example, information channel underestimating or reporting more or less correctly about the epidemic outbreak that was ongoing, their level bias in underestimation was different. So what happens is that if we're not able to correctly anticipate the future growth, we have clearly a bias in perceived risk. And this is happening both at the individual level. For example, it could affect my decision whether or not I go to a party, whether or not I go to mass, whether or not I go, for example, I do a travel. But it also affects in the same ways decision makers who are expected to take decisions on public health measures in order to better control and mitigate the impact of the epidemic on the population. And so it has an impact of individual, but also public prevention and control. And so that's the reason why we use models, because they help us rationalize in a quantitative and as much as possible unbiased way what is going to happen in the future and how to best respond to that. Now, one of the first big challenge that I think was highlighted very strongly with the COVID-19 crisis is that we have very good theory about models that can track infectious disease spread. And we have been working on these theories for the last 20 to 30 years, even though the very initial models of disease spreading date almost a century. And then we have data on the other side. And then, of course, we also are aware that with the digital revolutions in recent years, we had access to a massive amount of data. Now, to me, the biggest challenge that was also highlighted during COVID was the interface between theory and data. We have very good models on one side, quite a massive amount of data on the other, but do the two things match as we need them to be? And so to give you a little example, I provide you a context of the very, very start of COVID-19 pandemic. We were navigating in this big data optimism that somehow warmed up for the last 10 to 20 years. And then COVID-19 arrived, and in the initial couple of months, and I'm talking here about really January to March 2020, all groups like mine were desperately looking for, in Europe, for the number of ICU beds available per country. And here we're not talking about big data. We're talking about a single, simple, static Excel with about 20 entries providing us with these statistics so that we could use the statistics in our models in order to understand whether we would go over capacity of our hospitals or not. Now, the most updated statistics at that time were dating 2012 of this paper. And this data belonged within this, let's say, fashion of and optimism related to big data, we were navigating really in the dark. Today, and of course, what we do have is that we've been, also thanks to this last experience, we've been better able at improving this interface between models and data, and specifically trying to integrate not only traditional data, which generally are small data but high quality data, with non-traditional data. For example, I'm talking about mobility coming from different sensors, not exclusively from census statistics. Health data provided by individuals, or for example, also through online cohorts, sentiment analysis that is based on what individuals provide and write on social media, and also economic data, which can be more and more available also at individual, of course, anonymized levels. Now, this kind of data, generally so-called non-traditional data, are massive data, but at the same time, they are low quality. We have little information about individuals. Their power is really into identifying trends, population pattern, instead of having the typical type of data coming up with surveillance, which is high quality, so a lot of information about the single individual. And the big challenge is really trying to exploit in both, because each of them provide us with important information. Now, I take the example of mobility, which has been used traditionally to inform a spatial transmission for a long time, meaning that if you have an epidemic going on in a certain area, for example, emerging in a given country, then there are different means of spatial transmission of that disease to other unaffected area. This could be locally, for example, through commuting, through holiday travel. Remember, at the start of COVID-19 pandemic, there was one big issue that was the large mixing and travels within the Chinese population because it was a holiday period. So a lot of travels due to holidays. Then, of course, there is also international travel, which is the means for global dissemination. A virus emerging in China very rapidly reached the rest of the globe. And we can use this data already through models, even in very kind of simple analysis that allowed us at the very beginning, for example, of SARS-CoV-2 spread, to estimate which countries in Europe were at the highest and earliest risk of importation. And this was based on the use of International Air and Transport Association data of air travel flows connecting the affected area in China with countries in Europe. And these data are available at the airport level. So we were not only able to identify which countries were at the earliest risk of importation, but also specifically which airports were at highest risk of importing the first few cases. And notably, you can see from this color-coded map where darkest green means higher risk of early importation, you have countries like France, Italy, UK, Spain, and Germany that were estimated to be at higher risk because they were the ones with the highest connection through air travel with the affected area in China. And indeed, those were the ones who experienced the longest silent spreading throughout January, February, before the alert was issued by Italy at the end of February, and all of these countries realized that there was an ongoing, unseen, untraced epidemic within their own countries. But one can also use it in different way. For example, always in the early phase of the COVID pandemic, we looked at, again, the risk of early importation for African countries. And this time we put this risk of importation in relation with the country's capacity to respond. So we're looking at their ability to treat and deal with infectious disease spread, and their also economic and financial and structural capacity to respond to this type of outbreaks. And so this type of analysis could highlight the groups of countries which were both at the same time at high risk of early importation and low capacity. Those were clearly the focus for improved intervention, the needed improved and rapid intervention to increase their capacity rapidly in a very short time. Of course, much of my talk will be inevitably about COVID-19, and not because we have a specific fixation about the crisis, but because COVID-19 provided us with so much data, especially about behaviors and different epidemic contexts that evolved so rapidly over time. But clearly we do this type of approaches. We apply them to a lot of different disease outbreaks. And so, for example, even looking at the recent outbreak of Mpox that exploded in 2022, a few years back, and then from Africa, endemic areas of Africa arrived in Europe. Already there, by looking at the air transportation, one could have predicted that the virus from Europe would have moved then to North America, Europe behaving as a large exporter and North America behaving as a big importer of cases, and then spreading from North America to other areas of the world. Now, here we're talking about importation if we think about an emerging disease somewhere, or a disease that exists endemic in a given area, but suddenly for certain conditions becomes, travels away from the endemic area and start to infect other areas. But we can also use mobility in completely other settings. Here, for example, we studied migrations, seasonal migrations for jobs in Namibia to study high HIV risk flow. So what happens here is that there are, because of jobs, seasonal jobs, mainly related to mines in the north and to tourism along the coast and within the safari areas, male individuals move every few months from one area to another of the country. And by doing that, when they are away from their families, they may use commercial sex, which in a country where HIV is spreading at the general level in the human population, with also heterogeneous sexual spreading, becomes an important factor that increases the risk of transmission. And so you have these patterns of HIV risk flowing from one area to another of the country because of the seasonal migration and the opportunities to access commercial sex. One other challenge that is extremely important, and of course is related to the first one about the data, is human behavior. So generally host behavior, but if we're talking about humans, this is particularly relevant. So often there is a comparison that is being used between forecast and prediction that our models can do in the realm of infectious disease spread and, for example, weather forecast. Even under weather forecast, there is a set of extremely complex mathematical models that are fed with a lot of highly detailed and complex data, tracking weather up to the present in order to provide weather forecast for the short term. Now, the big difference is that those models deal with the fluid and mass gases and are directed by laws of physics. While instead, when we're trying to do forecast on pathogen spread in human population, the models that we're using are trying to predict human behavior. And so the big obstacle and really the very big challenge that is hindering our ability to provide predictions on the short or long term is whether or not we're able to capture and understand and characterize correctly human behavior now, and especially if we're able to predict how this human behavior will evolve in the near future. And so, and I think that in that respect, one citation from a review paper by Key and collaborators that was published throughout the COVID pandemic explains it very clearly, that one of the most important lessons that the pandemic taught us so far was that central forces shaping both local and global variation in disease burden and dynamics were social and not biological. And indeed, we know that it was the same pathogen, but the way we experienced it in France was different from other countries, were different from Italy, from the UK, and not exclusively because of the interventions that were put in place, but also because of human behaviors, the individual behavior that each person adopted. So we're talking about clearly control policies that were implemented by authorities, but also population response and also socioeconomic factors. And this is why COVID-19 pandemic represented an unprecedented experiment of extremely large perturbations to human behavior. And for us, it's a perfect laboratory to study human behavior and to learn, better learn for the next pandemic. And specifically, it puts in relation mobility with contacts, because the majority of these restrictions had their core restrictions on mobility, and their aim was social distancing, meaning reducing the opportunities of mixing and of contacts with other individuals. And to do that, we generally used mobile phone data. And there is a recent tradition of the use of mobile phone data for what is generally called the social good. This relates not only to infectious disease spread, but relates, for example, also to tracking population movements before and after earthquake and generally natural disasters. And also, for example, helping tracking refugee crisis where there are humanitarian challenges of big flows of migrants moving from one country to another. And in the realm of COVID-19, at the very start, there was a strong call that was made not only by the academic groups, but also by institutions like, for example, ECDC and European Commission, asking, for example, owners of mobile phone data to make them available and accessible to the academic community in order to respond. This is what we personally did because we had a long time collaboration with Orange that dated prior, many years before COVID-19 pandemic, that could help us also dealing with that crisis throughout the pandemic. And in order to give you a glimpse of what we were able to do, I start with two basic components of what do we need to model COVID-19 transmission. So there is in population. So there is one part that is what relates to the disease progression. So we need to understand how, once a person is infected, what is the incubation time, when the person starts to show symptoms, what is the probability to start showing symptoms, and also what is the rate of developing severe symptoms requiring, for example, hospitalization, and then possibly requiring ICU admission. Now, all of that is mathematically formulated through a model that is generally that is called the compartmental model, in which all these parameters are estimated from the literature or from available surveillance data. But then what relates to behavior is what determines the exposure risk of an individual and also the transmission risk. So whether individuals get in contact with each other. And one of the most important reference that is used in this case is a so-called matrix of contact, in which you divide your population in groups, generally age groups. Here I'm dividing the population into 4 age groups: younger children, teenagers, adults, and seniors. And you want to measure what is the mixing rate, so what is the frequency of their contacts depending on the age. This is coming from survey data, social contact surveys that ask each individual the type of contacts they had throughout the day with individuals of what other age bracket. And notably, these contacts are also stratified not only by age, but by setting where they occur. So they're divided by contacts occurring at home, at school, in the workplace, in the transport, or maybe there are contacts that were established during leisure activities or other activities. And also contacts, for example, whether they were physical, like shaking hands, hugging and kissing, or they were only conversational, so without a physical contacts. So we studied these data are available for a number of countries and covering all countries in Europe, but they were available prior to the pandemic. So when the pandemic started and we were already 1 month into the lockdown, what we could see from the hospital admission data was that the curve stopped to increase, but it was still we're still forming a cloud at the top of that curve, and it was yet unclear whether the epidemic was going to go down and decline because of the lockdown. And we were already 1 month into the lockdown, an experience that was unprecedented. So with the need for authorities to provide some feedback to the population on whether these measures were working or not, and what was the plan ahead. Now, the big problem is that, yes, we did use this contact matrix. There was a pre-pandemic contact matrix, which was available. It could help us reproduce the epidemic that was observed up to the lockdown. But once the lockdown was in place, we knew that majority of work was closed. All other activities were closed. Only essential workers were expected and allowed to go out of their household. And so that matrix was highly perturbed, and we had no way to inform that matrix. So what we did was to rely instead on mobile phone data that were provided to us by Orange in near real-time access with only a delay of 3 days. And so by looking at the sudden decrease of trips, of mobility observed within the cities in France right after the lockdown, we could translate that reduction of mobility, which meant essentially less people on the road, less people on the workplace, and so less contacts established by people, into a reduction of contacts. And so we synthetically generated a matrix of contacts throughout the lockdown. And by doing so, we were able to anticipate that indeed the epidemic was going to decline, that the lockdown was indeed working as a social distancing measure, and we were able to provide then this information to authorities before the monthly feedback on what just happened, effectiveness of measure, and what to do ahead. Now, I think it's important to note that, of course, nothing of this was prepared. So we had been working with Orange, but always with retrospective data. And we had to develop these ad hoc kind of inference from reduction of mobility to reduction of age-stratified contacts in real time. And we did that because Orange data were already available. We established a new contract with the company and were available to us, thanks also to a funding that we got from INR. At that time, there were no other mobility data available. Google started to release their first Google mobility reports just 1 week before we finished our report on the effectiveness, on the anticipation on the effectiveness of the first lockdown. But it's interesting to note that if we go back to the first document that was issued with the introduction of these mobility reports, the company was stating that these data were useful to inform delivery service offerings and to, for example, respond to the need to add additional buses or trains. Now, in my experience and to my knowledge, nobody has used this data for these objectives, whereas instead this data, together, for example, with the Orange data, became extremely useful to fight against the crisis. And so this also highlights how sometimes we're not able to anticipate how we could use some of the data because the context evolves so strongly, but that there is a need to have establish this partnership and engagement with private companies and data owners in advance so that it can be readily put in place once the crisis starts. And so then after the first lockdown was over, we entered a phase that for our modeling needs and requirements became even more difficult to model and to reproduce. During the first lockdown, it was most of a binary situation. Either individuals were staying at home or they were essential workers and were allowed to go out. And we could easily measure that through mobility. But then once the first lockdown was released, there was an initial phase out in which individuals were recommended to stay at home. They could do some smart working, but it depended much also on the free choice of individuals, whether they would go to work or not, probably based on their risk perception. Also, schools at that time in France were opened, but participation in attendance in presence was not compulsory. So authorities were giving the chance to parents to leave students at home and follow online in the interim before the summer closure. And then if we look more longer throughout the 2 years of the pandemic, we had moments in which we had curfews, so staying at home, but during limited amount of times throughout the day, then a third lockdown, etc. So what we did was to try to generalize our approach translating mobility into contacts, so reduction in mobility into a reduction of contacts throughout all of these different contexts. And in order to do that, we could not use anymore one single source. So we had to use a multi-source approach in which we're using, for example, Google indicators on the workplace presence. Google indicators to, for example, tune contacts during leisure activities. We use also school attendance data coming from the Ministry of Education over time and depending on the type of school. And we also use preventive behavior, so how risk perception translated, for example, into avoiding physical contacts, avoiding large crowding events, and these were survey data collected by Santé France. So we integrated all of these data to keep translating these changes in these indicators over time, which were responsible for the implemented actions by authorities, implemented measures and restrictions by authorities, but also how people responded to those measures, and then allowed us to translate how these changes in mobility and presence translated into changes into context and allowed us to continue responding to the epidemic. Now, of course, after the epidemic was over, the big question that remained for us as a scientist and also to improve our preparedness for the next pandemic episodes was, well, did we do good? Were our synthetic contact matrices informed by mobility changes a good representation of social contacts? And so to do that, we collaborated with another group that throughout the pandemic collected social contact data from surveys, so interviewing individuals and asking them to report their number of contacts throughout the day with people of different ages, except that this could not be done continuously over time, while instead our synthetic data, of course, were able to trace continuously and smoothly the change in population behavior. And this occurred only at specific times, which are the ones here highlighted by the different errors. So what we did was to compare our data obtained synthetically and instead with the empirical data. And what we found, here I'm plotting, for example, the population average number of contacts over time. The continuous line correspond to our synthetic estimation, and then instead the dots, the squares, the orange squares correspond to the empirical data that were collected from the surveys. And you can see that there are some moments in time in which the two agree perfectly, and instead other moments in which there is really large discrepancy, even though the overall trend is the same. So correlation is high. And what we found is that these divergences are mainly due to contacts established by children and adolescents, so established by the younger age classes. And more specifically, the two data agree best when schools are closed, pointing to the fact that probably we are not able on one side to collect disease-relevant contacts when schools are open through surveys, because we may overestimate, for example, the number of contacts that are relevant for disease transmission. And on the other hand, maybe synthetically, we're doing a poor job into characterizing these contact patterns among children during the summer, during the holidays, for example. But overall, what we found is that our synthetic matrices provided the best fit to reproduce the observed dynamics, better than the empirical data. And so this, if we want to put it in a perspective of preparedness and for next time, shows that these mobility indicators, even though they are of low quality, their real-time availability is of sufficient quality for good behavioral tracking. They are ready operationally in real time. They are also scalable for pandemic response, and they do not require huge costs because, of course, doing a survey, repeated surveys into population require a huge resources in terms of time and human resources. But there are issues that need still to be addressed concerning, for example, children. And then quickly, I'd like to mention a couple of other directions, because so far we've been seeing how, for example, mobility can be used to assess social distancing and how it changes over time, but it can also be a measure of inequalities and provide us with some insight into the sustainability of intervention. For example, when we first published our work and looking at Google indicators on workplace presence stratified by regions, you can see that all regions on the top plot show the same trends, but the red curve that corresponds to Ile-de-France shows a much larger reduction in presence at workplace. And so immediately, this was taken by the media with an easy, straightforward interpretation that Parisians were more respectful of restrictions. Now, this type of behavior was observed over and over throughout different types of restrictions, including, for example, second and third lockdown, including the curfews. So we were observing a differential variation, so reduction in mobility, reduction in presence at workplace, depending on the geographic areas. And so we started to ask ourselves, is it adherence? So is it a willingness of individuals to adhere, to comply with restrictions, or there are some rigid constraints that prevent individuals to comply to restrictions? And through a large multi-source data analysis, we were able to highlight that it was actually the second, that it was so that this response, differential response, was mainly driven by the job sector and other indicators, socioeconomic indicators like house crowding. Translated for explaining, for example, that plot, it shows that during, for example, the lockdown, a lot of job sectors that are predominant in the Parisian areas and in Paris specifically were closed. Everything that relates to tourism, events, museums, restaurants, etc., all of that was closed. In addition, many jobs in Paris are office jobs, so they could be worked from home. And so there were some, because of this job sector, present more specifically in Paris compared to other areas, this translated into a larger response. But it was not a mechanism of larger adherence, willingness to comply, but more induced by rigid job constraints. Then, of course, one can look into these type of things on different contexts, and socioeconomic elements become even more important when we look at low middle income countries, where of course you have an even larger disparity of socioeconomic conditions that could impact the way individuals respond to restrictions. And this is an ongoing work that we're running on the 2014-2016 Ebola outbreak in West Africa. But also sustainability. Approaching the third wave in France, to give you context, this is the spring 2021. We are approaching the alpha wave and the first new variant. Third time that France is approaching a third lockdown. And the big question was, is it better to put a high stringency and restrictive measure for a short duration, or instead using measures like curfew that are more moderate impact on the population on a daily basis, but they're kept for longer? So in this case, we still use mobility data to provide a synthetic indicator on the amount of distress on the individuals that was combining both the elements of stringency and the elements of duration, because this distress can accumulate over time. You may have a moderate measure, but if it is capped for 6 months, like curfew was capped in France for a very long time, it may take a toll then on mental health of individuals. And so what we found was that this is actually on the top, so there's a little mistake on this slide, but higher stringency and short duration measures, which is at the top, were providing similar distress as lower stringency and longer duration, but better hospitalization outcomes. And this was confirmed also with survey
Vittoria?
data. Yes,
Sorry, just for
I'm
a
closing.
minute, just to,
Yes,
yes, no problem, but
closing.
just to have the time for a question,
Thank you for telling
like
me.
5
Thanks.
minutes or, thank you.
Absolutely. And this was also confirmed from survey data that were coming from Santé, France, that were showing that anxiety was building up when measures were kept for a very long time, but fear was going down because fear of COVID was going down. So this anxiety was not linked to fear, because fear of COVID was going down, was mainly linked to a distress that was accumulated over many, many days of restrictions. And now let me conclude with, of course, I'll skip this that is about similar behavioral aspects on MPOX, and let me skip to the concluding elements. I wasn't able clearly in this length of the talk to mention all of these elements. But when we face a pandemic, even from a modeling point of view only, we have to face a lot of different challenges. They are related to everything that the data doesn't tell us, the silent spreading phase that we're unable to track with surveillance data, extreme uncertainties, an evolving landscape in our knowledge that is hard to gather, but also very hard to communicate so that authorities can take the appropriate decisions. There is a complexity of the response, which is generally not binary, but that is creating on a set of elements that go and build this response. We always face scarce resources. That's the biggest, of course, a permanent challenge of public health response. And then there is also two other elements of communicating forward. So communicating to the general public. In a crisis like COVID-19, it was extremely important to do that communication and explain scientific results in non-technical way. And also to a silence policy interface, understanding, trying to provide information while gathering the context in which those modeling results were obtained. That means highlighting, of course, the limitations of our approaches. And now for all of that reason, we created and launched in April this year, this Sorbonne Université Modeling Outbreaks Center that is built on these 5 pillars that, of course, relate to the elements that I talked about before. Human behavior, which is at the core of our ability to respond to epidemics. Public health that needs to become more precise in the way we, for example, assess the impact of measures on specific socioeconomic strata of the population in order to make these measures more equitable. From the little to the large, the global perspective, because we still need to have coordination globally so that a risk somewhere in one part of the globe doesn't become necessarily a pandemic risk. Clearly, these risks are coming not exclusively from human-to-human transmission, but there is an environmental and animal perspective that needs to be taken, integrated into a One Health and global health perspective. And then probably also rethinking our pandemic preparedness, in which next to different types of data and multi-source surveillance, we have to enlarge our paradigm of understanding pandemics, which cannot be exclusively fast and slow pandemic outbreaks, but that needs to integrate transmission routes, that needs to integrate also how population perceive that risk, because this will translate into their response. They need to integrate equity, impact not only from the epidemiological or healthcare point of view, but also mental health impact, also development impact, thinking about closure of schools, for example, and how institutions are prepared to all of that. And so I'll conclude my remarks here. I just want to flash that this is, of course, work that I presented that was obtained through very large collaborations among different institutions, and thanks to a lot of funders that help us conduct this work. And I'll close it here. Thank you very much for your attention.
Thank you, Vittoria. That was really interesting. So now let's jump to the question. Don't hesitate to ask your question in the chat. We have a first question, and that is, you have mentioned ICU bed availability as a factor of smoothing a potential pandemic, at least on national level, but have you looked into medical personnel staff availability? nurses, for instance, that are necessary to operate those ICU, especially incorporating this factor as a longitudinal variable.
This is a very important question. So no, we didn't, in the sense that unfortunately, when we do this type of models, and especially when we have to deal with them in real time, so provide a response in a short amount of time, it's hard to integrate a lot of additional data. So the assumption that we made is that hospital capacity was a good proxy also for healthcare resources associated to those capacity expressed into number of beds, which I know, of course, that is a strong approximation, but in that real time, we're not able to construct better indicators for that. We're also aware, and we did that in the first work, that those hospital capacity that were fixed number, of course, before the pandemic, throughout the first wave, they showed flexibility in the sense that the hospital system was able to expand the capacity, for example, in the most affected regions during the first wave, increasing, for example, the capacity of Ile-de-France even to up 50%, and that this is an extraordinary measure that should not be clearly considered as a stationary approach. But capacity is a big element that I think was started to be integrated into these models just with the recent pandemic. And this is definitely something that needs to be integrated better. So this is ongoing work.
Thank you. I have a question about, I read your quote about biological factor versus social factor, and I was wondering if social factor are, let's say, more important. How can we strengthen the dialogue between biological and social science to address this complexity?
Absolutely. Thank you for the question. This is very important. So we do that by doing interdisciplinary research. We have, of course, we do collaborate with social scientists. We have social scientists in the group. And then we continuously update our knowledge and theories with the knowledge and theories that are coming and results, of course, and empirical evidence that are coming from social science. I think that the big step that changed a little bit this collaboration was really the access to large quantity of data that, despite being of low quality in the sense that we don't have responses by individual, but we have traces that are collected as a secondary outcome by these individuals. Imagine, for example, mobile phone tracks. Still provide us with meaningful information. I wouldn't say that one is more important than the other. They both are important. They level, and they both, and this is something that we are trying to strengthen also in other contexts, for example, in the context of mpox epidemic. Even when we do have pharmaceutical responses available, like, for example, vaccination, there are still some limits that are at place. For example, how many people can we vaccinate per day? And so in the meantime, while we do that, the further support that a change of behavior in reducing the risk of exposure can help can provide at the population level in mitigating that curve is extremely important. So both are essential, and I don't think that one can go without the other. I think that the epidemiology of infectious diseases is probably moving, especially in a framework that is not STIs, where behavior has always been recognized as an important factor. But for respiratory infections, we're recognizing more and more, acknowledging the role of behavior in that context as well.
Thank you. I have a few more questions. So can you predict the impact of opening public parks during the pandemic?
I wish, because as many others of the participants, of course, I was missing very much the time in outside and especially in the nature. So it's very hard to do that in our models. If we had a nice observational, for example, experiment in which we could compare within the same conditions one phase of the pandemic in which parks were not closed and the moment in which parks were closed, we could do that. lot, but comparing them, it's very, very empirically, it's very, very hard because we're never in the same conditions. Now, through models, our models need to integrate as an input the amount of transmission in the parks. And so that is the reason why we cannot assess it, because we have to put that as an input. So that is the major problem for us. And that is the reason why we couldn't do it. On the other hand, we were able, for example, we did a lot of works on transmission within the schools and to provide and offer different protocols that could be applied within the schools in order to keep schools open. So that is something that we can do because we have good data on face-to-face contacts. We use radio frequency tags that measure face-to-face contacts every 20 seconds within a closed setting. And so that provides us with the input info that we need.
Thank you. One more question. Have you tried SIR type models also for competing COVID-19 variants, like Omicron versus Delta, to predict based on available early data to compute the infection rates for the different competitor viral variants, the potential prevalent future viral variants?
Yes, we did. So it was not an easy task because every time there is a new variant, clearly there is a lot of uncertainty around the characteristic of that variant. But day by day, really, this knowledge was becoming more and more accurate. And so we did integrate in real time different variants circulating. Luckily enough, in France, we always experienced at most 2 main variants circulated. Even when we had a third, it was generally negligible in terms of diffusion compared to 2 more competitive variants. And we had to integrate them and take into account their competition in terms of, for example, immunity. Because in some cases, like with the arrival of Omicron, there was cross immunity in terms of more efficient transmission, and also in terms of increased severity. So all of that impacted their spread into population and how this translated into hospital admission.
Thank you. So Arnaud de Guerra says, thanks, Vittoria, that was brilliant. Do you think there has been a significant effort from health authorities nationally and internationally to release more and better quality data since the COVID pandemics?
This is a very delicate point. So I give you, let's start from data. I'm a modeler, I start from data. In 2022, when Mpox arose and diffused from endemic areas in sub-Saharan Africa and arrived in Europe, including France, and started to be transmitted in the MSM community in France, we sort of expected better quality data and readily available data because of our experience in building capacity throughout COVID. And we actually had to face a system that was also exhausted, like everybody else, from the crisis. And so in terms of resources, in terms of energy. So right now, many countries are trying to reorganize the framework of data structure, organization, and access. And within the action coordonnée of modeling infectious diseases that is coordinated by the IReSP, we have a working group that I lead exactly in this direction on how to better improve the flow and access of data in a streamlined way from health authorities that collect this data to modelers that need to use it. Because clearly surveillance data is collected mainly for other purposes, but it can be repurposed for modeling. And given that I think we showed that modeling is one integral part that is essential in a response, we want this repurposing to be as more efficient as possible. And so this is something that we need to invest on.
I have a comment that says that to achieve precision public health, we need to integrate social data into surveillance and healthcare data. We are making progress, but we need to do better in France. I found it interesting.
I agree with that. And unfortunately, the problem is often that we have maybe good data about the population, about health, about socioeconomic information, about other elements that, for example, their risk perception response. Hardly they are integrated. So hardly we have a database in which we have all of this information for individuals. And that is why we are currently working with proxies. For example, we're using mobility data in order to infer that is something that can be done only by the companies themselves who have access to the individual data, which we don't have access to. They infer residence of individuals, and then based on the reference of the individual, they infer the socioeconomic conditions which are associated to the smallest administrative unit where that residence is located. And so we assign an inferred socioeconomic condition to a mobility track. And so to some extent, we're trying to build this association in absence of integrated data, where we have mobility behavior that can tell us a lot, as we saw, and socioeconomic conditions. But we're really at the start of doing that, and I think we still need to prove that it's benefit also for a response, and then maybe moving beyond that will prove the need for collecting this data.
Thank you. We are a little bit late, but there is only one more question, so I will ask her. Did you conduct a repartition analysis of the different NPIs, hard lockdown, curfew, increased availability of hygiene products, again in a longitudinal way to provide measure of efficacy for each of those sub-measures, of course correcting for each factor, vaccination statistically, if possible?
Yes, we did it. So not through a statistical approach, but we did it with our mathematical approaches, and we have good estimates we measure that into a reduction of the reproductive number in time. And so this can be done also discounting the elements that the person that were mentioned in the question. So, for example, vaccination and other elements. And so we're able to compare the efficacy of first versus second versus third lockdown, discounting for this element. And so we found, for example, the first was the strongest, but this is this is aligned with our personal experience, individual experience, I bet. And second and third were quite similar, even though they were built on different rules, inherent rules. On the third lockdown, we were told to spend more time outdoor, but not in contact. When instead, in previous lockdowns, we were told to spend more time at home. And so despite the changes, there were similar impacts in terms of reduction of R. And we did that also for the curfew, different phases of the curfew with different starting time, for example, of the curfew. And we found that it was actually more impactful than this was generally expected it to be.
Thank you very much. We have to stop now. I would like to thank you again for this very good presentation and for the question. I'll be happy to meet everyone again in January for the next session. You will have information really soon. And thank you again, Vittoria.
Thank you
Bye,
all.
everyone.
Thank you so much.
Have a nice afternoon, everyone. Bye.
Bye-bye.